Thank you. So, good afternoon, everyone. So, I'm Dr. Linu Jacob, lead discussant for the sarcoma MTB. I welcome all the expert panelists. I think we are having around 3 surgeons, 1 radiation oncologist, 1 general physician, and 1 medical oncologist in our panel. And I understand that there is no pathologist or a radiologist. So, I think all are free to give their inputs on the radiology as well as the pathology aspect. And before going into the presentation, I thank the organizers for this opportunity. And now let us start the proceedings. Let me ask Dr. Sreevalli to present the case.
Thank you, sir. So a very good morning to everyone. I'll be presenting the sarcoma case. So presenting a 17-year-old female who presented with the chief complaints of pain in the left chest and inframammary region for 10 months duration, followed by swelling for 15 days duration. Pain was severe, radiating to back of chest. There was no history of fever, weight loss, or loss of appetite. No history of cough, breathlessness, or swelling anywhere else in the body, with no significant past personal or family history. With the above complaints, she was evaluated elsewhere. Her complete blood count and biochemistry were within normal limits. Bilateral breast sonography revealed well-defined hypoechoic lesion in left lower anterior chest wall, measuring 2.7 into 1.2 centimeter, which was further confirmed by CT thorax. She underwent an FNAC from this lesion, which was suggestive of lymphoproliferative disorder. With this background, she came to our institute. On examination, her ECOG performance status was 0, vitals stable. Local examination revealed a 2 into 2 centimeter tender firm swelling in left inframammary region with no palpable adenopathy. Rest of the system examination were normal. So what could be the differential diagnosis in this 17-year-old female with a left chest wall lesion? The first thing we considered was PNET bar Ewing sarcoma. With the outside report of the FNAC suggestive of a lymphoproliferative disorder, our second differential was lymphoma. The third one we considered a soft tissue sarcoma. We worked her up in these lines. Her complete blood count, biochemistry, serum LDH were within normal limits. Viral markers were non-reactive. She underwent a PET-CT, which showed a hypermetabolic, homogeneous left medial anterior chest wall lesion at the level of left fifth rib. It was 2.5 into 1.4 centimeter with an SUV of 2.9. There were multiple scattered bilateral lung nodules, largest in the right upper lobe, measuring 8 mm with an SUV of 3.2. So this is the PET-CT report. She underwent a USG-guided biopsy of the left chest wall mass. So the whole mount view, 10x, 20x, and 40x magnification are as seen in this slide. It showed malignant spindle cells which were arranged in interlacing fascicles with no necrosis, mitotic activity in the range of 10 to 12 per 10 high power field, suggestive of a spindle cell neoplasm. She underwent IHC, in which the tumor cells were immunopositive for Vimentin, BCL2 with aberrant expression of CD99, weak P53 positivity. They were negative for CK, CD10, 68, 34, SMA, myogenin S100 and Desmin with a Ki67 of 10 to 12%. Thus, the IHC favored a spindle cell neoplasm of intermediate grade with the possibility of DFSP, dermatofibrosarcoma protuberans.
Yeah, thanks, Sreevalli. So just to summarize, so we have a 17-year-old girl with a left chest wall swelling, which was associated with pain, and an examination which showed an approximately 2 into 2 centimeter firm tender swelling in the left inframammary region, and the PET confirming a hypermetabolic lesion in the chest wall at the level of the fifth rib, and with scattered bilateral lung nodules, the largest of which was around 8 millimeters. And the FNA report was suggestive of a lymphoproliferative disorder, and the subsequent biopsy suggesting that it is a spindle cell neoplasm, possibly a dermatofibrosarcoma protuberance. So my question would to the panelists would be, the expert panel would be on the diagnosis, like whether they agree with the diagnosis of the dermatofibrosarcoma protuberance, what other possible differential diagnosis do they think, and whether they would like to have a review of the histopathology slide and blocks. So I think the question is open to all. So anybody can take, as I told, because we don't have pathologists and radiologists, so everybody can pitch it. So maybe if Dr. Kunal is there, Dr. Kunal?
Yeah, I'm there. I'm a radiologist and intervention radiologist.
Yeah.
Yeah. So coming on to the PET CT scan, so there was a mass lesion which was located in the left chest, anterior chest wall. It was not eroding the bone, and it was not going into the into the mediastinum or the chest per se. So this was a superficial lesion which was there. So it could be dermatomyofibrosarcoma. Okay, but first differential would be PNET, soft tissue PNET, or Ewing sarcoma, soft tissue PNET or Ewing sarcoma. Okay, but the biopsy would be certain. Biopsy was certainly different from that. And another thing, there are multiple lung nodules. So these lung nodules were solid in nature, and these were well defined and were around 6 to 8 millimeters in size. So if they are 6 to 8 millimeters in size, so they would come into intermediate zone. This would require, these are indeterminate nodules, and has to be CT scan needs to be repeated at the 3 month interval. If there is no progression of these lesions, then they would be considered stable or benign or indeterminate lesion, and these need to be kept under observation or a follow-up.
Yeah, thank you, Dr. Kunal. So maybe to the orthopedics, the surgeons who are on the panel, so what do they think about the differential diagnosis, and what would be their differential diagnosis, and what do they think about the diagnosis of dermatofibrosarcoma protuberans?
So from a surgeon's perspective, one thing I would want to have is an MRI, which will tell me whether there is any involvement of the underlying bone. That will be, because that will be better seen on MRI, and it is not, even the PET CT scan we have seen minor marrow involvement sometimes are not visible. And of course, CT scans usually don't tell us whether there is any bony involvement or not. If on MRI, we are certain that this is a soft tissue mass, from a surgeon's perspective, it doesn't really matter whether it's a DFSP or some other sort of sarcoma, because ultimately we are going to go in for a similar type of a wide resection. Whether this could be DFSP or not, as far as I understand, the DFSP would involve the inner layers of the skin, and in this CT scan, whatever I saw, the skin was pretty much uninvolved. So I would certainly be not be very happy with diagnosis of DFSP, and I would want a review of the histopathology, maybe from a more sarcoma savvy or sarcoma specialist type of an MSK histopathologist. So that is my take on this particular case so far. As far as the CT scan is concerned, the whatever images were provided to us, it didn't really look like metastatic to me, because typically the metastatic sarcoma nodules would be more rounded, more dull, more peripheral, not in continuation with any bronchovascular markings. And so even if they are less than 1 centimeter or 6 to 8 millimeter, but if they are like this, rounded, dull, very well defined on the peripheral part, I would be considering them as metastatic and keeping them under close watch.
Right. So I think from the differential diagnosis perspective, probably if it is a soft tissue sarcoma, which we consider in this particular age group, probably the first thing which would come to our mind would be a rhabdomyosarcoma, because this girl is only 17 years. The other would be Ewing's and PNET, and the other common being undifferentiated pleomorphic sarcomas, and then malignant peripheral nerve sheath tumors, because DFSP is rare in this particular group. Bone sarcomas, of course, the imaging does not show that it is arising from the bone, nor the clinical examination was showing that the plane of the swelling is not arising from the bone. So, but if bone is considered, then probable diagnosis would be an osteosarcoma or a chondrosarcoma. And since the FNAC was suggestive of a lymphoproliferative disorder, the lymphoma which we can think in this age group would be an anaplastic large cell lymphoma. And regarding the pathology aspect, Dr. Bharat Rekhi has volunteered, so maybe her comments.
Yeah, thanks for the opportunity, Dr. Jacob. I was just seeing the slides and so CD34, so morphology here is not of a DFSP. CD34 positivity has to be consistently seen in a DFSP. That is one marker. Only if a DFSP has undergone a sarcomatous transformation, then it loses CD34 patchily. Now, having said that, if you can just move the slides before I can have a relook at it, and I could realize the markers positive are BCL2, I think. Can you just move a slide?
You can go back.
Yeah, so this is not the usual morphology of this is a spindle cell sarcoma. So Ewing sarcoma goes out right away because you will not see spindle cells in a Ewing sarcoma. It's a round cell sarcoma. So next slide, can we move to the next slide? Now with the immuno panel, because I can't see the immunostains, but let me have a look at the immuno, yeah, so I can read out here that there is aberrant expression of 99, which generally is not a very useful marker, but we use it for Ewing sarcoma and BCL2. So if it's a spindle cell sarcoma, which is showing you BCL2, a thought of synovial sarcoma is one of the differentials one can consider in tumor like this. So that's all I can say here, but I would have liked to test. Now you said rhabdomyosarcoma, I can see myogenin is negative. Of course, we do Desmin and myodevon also for rhabdomyosarcoma, including spindle cell type, which can be a differential here, as you mentioned. But I think I don't see Desmin being done here, but myogenin is a skeletal muscle specific marker. Kind of softly takes away the possibility of a rhabdomyosarcoma. But it's a spindle cell sarcoma, and one of the possibilities I could think here is, a synovial DFSP is out here, I think.
Yeah. So being a spindle cell neoplasm, as you told, Ewing's and PNET as well as lymphoma is out. And then what do you think would be the role of IHC in a spindle cell neoplasm? How useful IHC is in a spindle cell neoplasm in differentiating?
It's very, very useful. I think you put a very right point. So it's generally IHCs are morphology driven. So we look at the tumors, how they look in terms of their patterns, and accordingly choose the markers and the panel. So if it's a superficial tumor, which looks a very storing form pattern, I would throw in a CD34. And if it's CD34 diffusely positive, when I say all cells, you can reinforce a diagnosis of DFSP. They're generally, superficial tumors, not very, very deep-seated. If you have a spindle cell sarcoma, which is looking like Ewing's, perhaps, and monomorphic short spindle cells, we call herringbone pattern. People used to call that as fibrosarcoma earlier. You should think a possibility of synovial sarcoma, because spindle cell sarcoma and Ewing sarcoma and synovial can be morphological overlaps. Now, Ewing sarcoma, we don't use the word peanut anymore. It's a round cell sarcoma. If you start seeing the spindle cells in a Ewing, you should think of those new entrants. Now we have the BCORC CNV3, the undifferentiated, genetically defined sarcomas. So these are more common I can think about. And of course, if you see some pink cells, we call them rhabdomyoblastic cells, in a spindle cell sarcoma, we throw in Desmin, myogenin, myodevon for a spindle cell rhabdomyosarcoma. And of course, we have S100 and SOX10 as markers for the MPNST, which is another spindle cell sarcoma, which comes in the differential of these tumors. And now we have the histone protein also for the malignant peripheral nerve sheath tumor. So essentially, DFSP, synovial sarcoma, MPNST, these are classic spindle cell sarcomas, and Ewing's is invariably a round cell sarcoma. And of course, spindle cell rhabdo is a rare entrant for a spindle cell sarcoma.
Yeah, so I think there is agreement that definitely the histopathology needs to be reviewed, especially for sarcomas. There can be many times discordance between pathologists. So we also decided to review the histopathology, and then let's see the histopathology review. So the histopathology review here showed again spindle cells express EMA, MIC2, TLE1, and SS18, SS6. And immunonegative for cytokeratin and S100, and it was reported as a monophasic synovial sarcoma. So next slide. So any comments from the panelists on synovial sarcoma of the chest wall and on the specific type of monophasic synovial sarcoma? Maybe Dr. Prakash Naik.
Yes, thank you, Dr. Jacob. So there were two other critical points because of which I felt this could not be a DFSP. One was the young age. Two, clinically, this girl had a lot of pain. DFSPs primarily are unusual at this stage. They do not usually present with pain. And the FDG avid lung nodules. And now synovial sarcoma fits in. And now I'm beginning to get more worried about the FDG avid lung nodules, and I want to be sure if they are too small to characterize or they are metastatic. When it comes to the point of monophasic versus biphasic, it does not have immediate relevance when it comes to treatment. It does not have a big bearing when it comes to prognosis. It will have some difference based on how difficult it is for the pathologist to report. But considering we suspect a synovial sarcoma, some centers would still go ahead and confirm it with an RT-PCR for SYT SSX translocation studies, which would take any element of doubt away that it is a synovial sarcoma. And then the presence or absence of metastasis to me is a big determinant on my intent of treatment and what I would do further. Over.
Yeah. To Dr. Bharat, since they have already done the IHC for the SS18 and the SSX, would you still advise a FISH study or a translocation X18?
I'm very reassured with the additional panel of IHCs that you just threw in. So TLE1 is a good marker to reinforce a diagnosis, but of course it is not entirely specific. We always match morphology to the markers that I strongly believe in. SYT SSX2 is now a very good marker that you just showed, but I think you mentioned it's a dim expression, right? It's an excellent paper of Jason Hornick which mentions about its diffuse expression, and it's kind of parallel towards a excellent trade-off for the, what shall I say, molecular. So if you've got a strong SYT SSX protein, which is like the latest marker with TLE1 in this morphology, I could go for a synovial sarcoma, but I'm only concerned about this dim expression. And if it was TLE1 and SS18, SSX diffusely, I wouldn't go for, as the literature mentions about the utility. But since it's a dim expression, as Prakash mentioned, we can be more certain to go for a FISH, which I believe more than the PCR. So we do FISH here, and it takes care of more than 95% synovial sarcomas with high, I think 100% specificity and more than 95% sensitivity. The SS18 gene rearrangement, only because it's dim. If it was strong, I would have said you can, get away with the molecule at this point in time.
Yeah. So moving from the diagnostic issue to the staging issue, so we all saw that the PET-CT showed bilateral lung nodules, of course, less than 1 centimeter in size. So my question to the panel would be how to characterize the lung nodules, whether metastatic or not. Do you have any specific points to tell that, okay, it is METS or it is not METS, and the reliability of the imaging, the role of PET-CT, or whether you would go for a tissue sampling? So maybe I would ask Dr. Venkatesan Sampath to pitch in.
Yep. Thank you very much for the invitation. So with regards to the lung nodules, I would still keep it under suspicious nodules because of the number. Although the size is less than 1 centimeter, the PET-CT still shows an uptake. And we all know that synovial sarcoma is a high-grade tumor. So, and it has quite a good chance of metastasis as well. So these nodules, I would keep them as suspicious. And in terms of biopsying these nodules, I don't think I would go for a biopsy straight away. Rather, we start the treatment assuming that these can turn metastatic down the line. Means on treatment, if the nodules are going to progress, then we would definitely consider them to be metastatic. Or if, as told earlier by radiology colleague, if they are going to remain as benign or indeterminate, even then we would like to watch these nodules closely.
Okay, thank you. So the false positivity rate for pulmonary metastasis with the chest CT can be as high as 12%, and it can go up to 40% when the nodules are less than 6 millimeters in size. And as far as PET-CT is concerned, I don't think there is an advantage for PET-CT over CT. And to confirm the diagnosis, whether it is really metastatic or not, the only way is to have a tissue sampling. So we discussed this particular case in the our the multidisciplinary tumor board, and some were of the opinion that the nodules were not characteristic of METS, but some of the radiologists were of the opinion that you can't still neglect it, and then you need to confirm it by tissue sampling. So final decision was to go ahead with excision of the chest wall tumor, and in the same sitting to go for a thoracoscopy and biopsy. So so supposing if let's say that we have decided to go for a biopsy, any takers for open biopsy versus thoracoscopic biopsy?
So I have a quick point to make. I recall the largest size on the PET CT was 8 millimeters, and the SUV avidity was about 3.5. I would not hesitate taking this back to both my thoracic colleagues and my radiology colleagues, because it crosses the TSTC, or the too small to characterize threshold of 5 mm. It's definitely more in the indeterminate zone. I will leave it to them if they think if an 8 millimeter nodule. No, because in this individual, it's going to change my intent and my therapy by a huge fraction. If these are TSTC, I would probably operate, radiate, and see what to do. If these are certainly METs, I would probably give upfront chemotherapy in this instance and then see what happens to the lung nodules. So distinguishing these is very important. If both of them tell me that no, we cannot palpate or biopsy it, no, we cannot needle it, then I will consider them indeterminate, repeat a scan at 8 weeks to 3 months, treat the primary. But if either of them tell me, no, we suspect this is metastatic, yes, we can needle it, or we can put in a VATS probe and take out a couple of them, then I would go ahead with that. I don't recall what the count was on the CT thorax, and I would rely on a plain breath hold CT thorax for the exact count, not the PET CT thorax. Thank you.
Yeah. So to cut the story short, the patient was so it was decided to go ahead with the wide local excision of the lesion, and the thoracic surgeon decided to wire localize it before the VATS, because the nodule was small in size. And one day prior to the surgery, the patient underwent a CT, and the CT could not visualize those nodules. And finally, the patient underwent just a wide local excision. Final histopathology report. Next slide. So the final histopathology report showed that it is a malignant spindle cell tumor arranged in interlacing fascicles. And on immunohistochemistry, the cells were positive for MYC2, negative for CD34, and occasional discrete cells showed positivity for cytokeratin, that is AE1 bar AE3, and with a MIB labeling index of 25 to 30%, and it confirmed the previous preoperative biopsy diagnosis of synovial sarcoma. So here we have the case of a monophasic synovial sarcoma of the left anterior chest wall with a T1 lesion less than 5 centimeters, no nodal mets, and FNC LCC grade 2 and stage 2. So next slide. The question open to the panelists would be, what would be the role of adjuvant RT, the role of adjuvant chemotherapy, and what would be the prognosis for this patient and how to follow up this patient. So to Dr. Jifmi Jose, radiation oncologist.
Hello. So this is a case of monophasic synovial sarcoma. So considering that we have done a wide local excision, the margins are negative. This being a high grade, treated as a high grade sarcoma, it warrants adjuvant RT. So the quantum of benefit in general we would say that it is around 20 to 25% in local control. So there is no difference in overall survival. And so there is always a debate that whether we can avoid RT given that this is a T1 tumor. But with the current studies, in the absence of randomized controlled trials which compare RT versus no RT in T1 high grade tumors, we must continue giving adjuvant RT with conformal techniques, or at least explore brachytherapy. So this is a suitable case for brachytherapy, and it would be beneficial because it will reduce the overall treatment time, as well as treat the tumor bed in a very very concisely and nicely. So this is one thing that I had to say. And the next one, what I need to answer is indications. So in margin negative sarcomas, we advise adjuvant RT in all high grade tumors, and in low grade tumors, those that are more than 5 centimeters, or in recurrent tumors. So in margin positive, when there is a presence of gross disease revealed in radiology or on palpation, so if revision surgery is contemplated, adjuvant RT follows. Or when there is no gross residual and revision surgery is not contemplated, we go ahead with adjuvant RT, but just that the dose would be higher. It would be around 66 to 70, depending on the gross disease, if gross disease is present or not. Otherwise, in a margin negative case, it would be 60 gray in 30 fractions over 6 weeks. Talking about pre-op versus post-op radiotherapy, there is a randomized control trial that has compared these two modalities, and there has been no difference in the local control, DFS or OS. So though the preliminary analysis did say that there is some benefit in OS with preoperative radiotherapy, the later on the long-term results showed that there is no difference. So in disease control wise, there is no difference between both these modalities, but obviously their toxicity spectrum and their advantages are actually different. So talking about the toxicities, preoperative RT actually has a higher risk of acute complications, while postoperative RT will give you slightly more of long-term complications like subcutaneous edema or fibrosis as such. So, and also about the advantages, preoperative radiotherapy is universally now most of the centers have moved towards preoperative RT is because of the many advantages, such as you need to give lesser doses. That is, we give 50 gray in 25 fractions for preoperative RT, while you need to give 60 gray in 30 fractions, even in margin negative cases in post-operative setting. So you need to give a lesser dose, but their target delineation is better. You have lesser long-term complications. Are few of the advantages of preoperative RT, and in postoperative RT, we would have. There is a better staging as the surgery is done upfront, and you get a better evaluation of the surgical specimen, and there are lesser acute complications. So one point I would like to emphasize in this is, though pre-op and post-op brachy in control wise is the same, just that the toxicity profile is different. What we lose out when we push a lot for preoperative RT is that the chance of assessing the feasibility for brachytherapy. So in post-operative RT, when the surgery is done, you can evaluate the tumor for a brachytherapy, which will reduce your overall treatment time, which benefits the patient as well as the institute. And the last question was about brachytherapy versus EBRT. So again, there is a study published by Electiar et al. Who has compared, not in a randomized fashion though, he has retrospectively compared the results between brachytherapy and EBRT, and he concludes that the control in EBRT with IMRT, intensity modulated radiotherapy, is much better, and the toxins, So this study, though published, and because of which many people have tilted towards external beam radiotherapy, has certain loopholes, as in brachytherapy, as in all other sites, has to be in a well selected population. You need to assess whether the tumor bed can be covered well with your application of the interstitial brachytherapy tubes. This has to be done well, and also we need to look at the advantages. Giving brachytherapy, as I mentioned before, is beneficial to the patient, as it reduces the overall treatment time, and this benefits the institution as well, especially in the setting of a high volume center. And it does cost implications, but there is a challenge of the technical expertise. So over on to you back.
Right. So I think in this particular case, definitely you will give adjuvant, right?
And we need to assess for brachytherapy.
Yeah. And finally, coming to the last question, the role of adjuvant chemotherapy, maybe Dr. Prabhat Bhargava, medical oncologist.
Thank you for the opportunity. I would avoid giving adjuvant chemotherapy in this case, as the patient has a superficial tumor in the axial skeleton. So there will be very less quantum of benefit would be less than 1 or 2% in this patient. Had it been an extremity or more than 5 centimeters, there would be some indication. This being a superficial chest wall lesion, we can avoid adjuvant chemotherapy.
Yeah. So, do you use any normograms or circulator, some calculators to decide on the quantum of benefit from adjuvant chemotherapy in your practice?
Routinely no, but because they are not standardized in the Indian patients. But yes, we can use them in patients where there is we are confused whether to give or not to give. There, yes, we can.
So I think in this case, being the tumor being less than 5 centimeters, it is stage 2, the FNC LCC grade being only 2, you feel that there is no role for adjuvant chemotherapy, right? So I think Sreevalli, you can show the last 3 slides quickly and then conclude.
Okay, sir. So summarizing whatever we discussed, need for adjuvant radiation in deep, large tumors more than 5 centimeter, high-grade tumors, grade 2 to grade 3, and those tumors with R1 and R2 margins. So preoperative RT, as we understood, it allows for use of smaller radiation fields and lower doses. So other than the dose difference between pre-op and post-op RT, it is associated with similar control and disease-specific survival. Brachy versus EBRT, brachy minimizes the RT dose to surrounding tissue, maximizing the dose delivered to tumor and shortens the treatment time. So the adjuvant chemo evidence, as per the 1997 SMAC meta-analysis and 2008 meta-analysis, there has been an absolute improvement in the disease-free survival with adjuvant chemotherapy, as well as an absolute risk reduction in the recurrence. So in the SMAC meta-analysis, seeing the local, metastatic, and the overall disease-free survival, there was an absolute improvement in 6, 10, and 10% respectively, with a 4% absolute benefit in overall survival. And in a subgroup analysis, the extremity sarcomas had 7% absolute improvement. In the 2008 meta-analysis, seeing the absolute risk reduction in local recurrence, distant, and the overall recurrence, there was 4%, 9%, and 10% risk reduction respectively, with a survival benefit of 6% for all combined chemotherapy. Considering only ifosfamide and adriamycin, the absolute risk reduction was in 5%, 10%, and 12% for local, distant, and overall recurrence, and 11% survival benefit. So adjuvant chemo is indicated in deep tumors, high grade, and large tumors more than 5 centimeter. So coming to the take-home message, sarcoma is a tumor type where there can be a considerable disagreement among pathologists regarding the specific histologic subtype and grade, as we saw in our case, up to 35% discordance rate. Assessment should be done by pathologists with expertise in STS. False positivity rate with CT chest for pulmonary metastasis being 12% overstaging, which can go up to 40% with small indeterminate nodules less than 6 mm in size. Role of PET-CT is limited in evaluating pulmonary metastasis less than 1 centimeter. Tissue sampling to be done to confirm the mets in such cases. Treatment being multimodal, multidisciplinary, and needs to be individualized. Thank you.
Thank you. Thank you to all the panelists, as well as thank you to the chair.